So for the BOAS syndrome, we have this array of anatomical abnormalities that we see in these cases. And it's when one of these becomes sufficiently severe or they're coexisting in the same animal that we can end up with a situation of partial respiratory obstruction. And this is part of the problem, isn't it? We all know the difficulties these animals have, but they're so goddamn cute. I love them, they're such characters, and I think that's partially what perpetuates their popularity. So obviously, you know, we have a wide variety of brachycephalic breeds, and probably all the brachycephalics we see have some degree of airway abnormalities. But really, when we're talking about BOAS, these breeds are the three main culprits, so the French and English bulldogs and the pugs, and it's really these ones that we're going to be focusing on today. Now, to be honest, it's not very often that I write an absolutely new talk these days. I usually have something prepared that I can kind of put together from some of my other talks. But this is a brand new talk. I've never done this before. So I sat down and I thought, okay, where will I find information about current thoughts on BOAS? So where do we all go? We go to the internet first. And there's loads of information out there when you look. As soon as you go on there and you type in pug anaesthesia, French bulldog anaesthesia, you come up with an array of things. And it's really interesting to get the tips that I got off the internet. So apparently it's the pre-medication that causes all the problems with these dogs, and we should really just mask them down. I like this, I have my vet mask down. It's as if they dictate exactly how we perform anaesthesia. So that was the first thing I came to. The next one was we shouldn't be using barbiturates to sedate the patient. I didn't know we used barbiturates to sedate patients at all. So again, they then go on to say really that we should be minimizing the amount of drugs apart from inhalational anesthetic agents we give these patients. So again, suggesting mask induction. The third one I thought was even more interesting. A vet does have to insert the isoflurane, spelling not mine, the isoflurane breathing tube down and into your dog's throat. But to do this, in my opinion, it's not necessary to inject anything. Now, I'm assuming when I read that at first, I thought, but the more I think about it, I think they're actually talking about mask induction of anaesthesia. Initially, I thought they were thinking of a conscious dog and trying to ram a tube down its throat. So the consensus on the internet is very much that we should perform in mask induction of anaesthesia in brachycephalics. And then there's this whole big thing, I'm sure a lot of you have come across this, about acepromazine. Acepromazine being a drug of the devil. And if I had £1 for every time I had heard this from a Frenchie owner or a pug owner, I would be even richer than I am just now. And that would be saying something. But you see all these things on the internet, on all these forums, and you think, well, is this just the ramblings of owners of these breeds? Are they just misguided in their opinions? But as you delve a bit deeper through all these forums, it all comes back to one person. Now, this is seemingly unbelievable. And this is Laurie Hunt. Now, Laurie Hunt is a French bulldog owner and breeder in the States, and she also happens to be a practicing veterinary surgeon. And she produced an anaesthetic protocol for Frenchies, and subsequently all the other BOAS breed societies have adopted this same protocol. And this is everywhere on the internet, and it can all be traced back to Laurie. I don't know her, but she's come up with some funny ideas. Now, you can be sure if I wrote an anaesthetic protocol to put on one of these breed sites, I would get shot down in flames. They would say, you don't know what you're talking about. But because she's one of their own, it's been accepted, and this has literally become viral across the whole internet. This is how you must anaesthetize a pug or a French bulldog or an English bulldog. Let me say to you that most of what you're going to see on the internet is absolute nonsense about this. There is zero evidence at all that acepromazine is unsafe in brachycephalics. Obviously, we may have an issue in boxers. Some boxers clap with acepromazine. Doesn't mean to say it's contraindicated. We just need to be a bit cautious with our doses that we use. But equally, this is surprising for an anaesthetist to say, the anaesthetic drugs are probably the least important part of a successful BOAS anaesthetic. And I'll talk to you about what I mean by that in a second. Sorry, I've got a cough, which is why my voice keeps wavering. There's a lot of similarities between the BOAS situation we see in our patients and obstructive sleep apnea in humans. Now, obstructive sleep apnea is very common, and I'm sure a lot of you will have experienced it. You're lying in bed with your partner, they start snoring, and then suddenly there's silence, it stops, and you look across, and they're apneic. And then nothing happens for about 10 seconds, and as you're about to call the ambulance, they suddenly go and start breathing again. And interestingly, there was some work at Penn Vet School in the States in the late 80s where they used English bulldogs as a model for human sleep apnea. And what they found in that study was that these bulldogs, when they're asleep, desaturated dramatically. Their oxygen saturations were falling into the low 80s when they were asleep. And they also had these intermittent long periods of apnea that we also see with obstructive sleep apnea in humans. And because of this disturbed pattern of sleep, these dogs were fairly sleepy when they were awake. And in fact, what they did in this study was they had a darkened room with a cage, a nice quiet room, and they put the bulldogs in these cages, and they did the same with their control dogs, which were not brachycephalic. And what they found was that the English bulldogs fell asleep in an average of 12 minutes after they were placed in these cages, whereas the other dogs, the control dogs, took over 150 minutes to fall asleep, and most of them didn't fall asleep at all. So what we know from this study, and I think it's something that we don't really think about as a health problem in our BOAS cases, but these animals are almost certainly chronically sleep deprived as well, because they have this, essentially this obstructive sleep apnea going on. So that's a welfare issue as well, aside from all the other problems that they have. But probably even more important is that we know from human work obstructive sleep apnea is associated with increased anaesthetic risk. So patients with OSA are very commonly markedly hypertensive. They also are prone to hypoxemia, and they're predisposed to cardiac disease. Now, we don't know whether all these things happen with our BOAS cases. We know they become hypoxemic. There's lots of studies looking at this. But we don't know whether they have this risk of heart disease associated with the BOAS situation as well. So for human patients with obstructive sleep apnea who are going for anaesthesia, to try and decrease this risk, they do two things. The first one is institute a weight loss program if they're overweight. And the second thing is they get them to wear a CPAP mask or a CPAP hood. So CPAP is continuous positive airway pressure. And what it means is when you try and breathe out, the mask or the hood exerts a resistance against that. So you need to apply more pressure to exhale. And that pressure pushing back against you helps keep your airway opened. Now, obviously, that suggests that all we can really do for our BOAS patients, if they're coming for an elective or semi-elective procedure, is make sure we get weight off them, get them down to a normal weight. Now, I know that's easier said than done, but particularly with this type of airway, any extra weight is a significant risk factor. So we try and get them as thin as we possibly can. The other issue that we face when we're anaesthetising BOAS cases is the huge instance of gastroesophageal abnormalities in these dogs. And in fact, in a 2005 study by Ponsett, they showed that 97% of brachycephalics had gastroesophageal abnormalities. Now, this study was looking at clinical signs, was looking at endoscopic findings, and also histology of the gastric mucosa. And as I say, 97% of the dogs had an abnormality. They don't all show clinical signs, but what they did find in this study was that there was a positive correlation between the intensity of the gastrointestinal signs and the respiratory signs in French bulldogs, in male brachycephalics, and in heavily built brachycephalics. There was a more recent study in 2018, and what they were scoring on, they were looking for signs of salivation, thylism, regurgitation, or vomiting. And they found that 56% of brachycephalics had an instance of one of these things going on. But if you look at the distribution between the three main BOAS breeds, 93% of French bulldogs had obvious signs of gastroesophageal disease, 58% of English bulldogs, and then we're down to about 16% in pugs. And in this study, all the dogs underwent soft palate resection, staphylectomy, and they had stenotic nares resection as well. And what they found was there was a significant improvement not only in the respiratory signs, but also in the gastrointestinal signs post-surgery. And this was particularly the case in the French bulldogs. They had a dramatic improvement in the gastrointestinal signs. So there's a whole kind of range of gastroesophageal abnormalities that we see in these breeds, but the ultimate thing that happens is we have a high incidence of gastroesophageal reflux. This is particularly problematic for us because it means if the reflux during anaesthesia, there's the potential for regurgitation and subsequent pulmonary aspiration and developing an aspiration pneumonia. Now, we know that some of these breeds, even when they're conscious, are overrepresented with aspiration pneumonia, particularly English bulldogs. We see quite a lot of them that present with this sign. So the gastroesophageal reflux is a significant problem when you're dealing with BOAS anaesthetics. So how do we try and reduce this problem? How do we try and minimise the risk of gastroesophageal reflux? Well, obviously we fast prior to anaesthesia. And the optimal length of fasting is something that's fairly controversial. I guess most of us probably aim for something like 6 to 8 hours of fasting. In fact, there is some evidence that you can reduce the incidence of reflux by giving a small meal to the patient about 3 hours before an anaesthetic. Now, that's been refuted by a subsequent study, so the jury's still a bit out. But there is a school of anaesthetists who think we shouldn't be fasting for this long, but we should be given a small meal closer to the time of anaesthesia. Certainly what we do know fairly convincingly is that the longer we fast for, the higher the incidence of gastroesophageal reflux. So if you fast for like 15, 20 hours, you're more likely to have the patient reflux during anaesthesia. So an adequate period of fasting. The next thing we do is studies from Cambridge Vet School, Ambra Panty, who's an anaesthetist in 2009, and her colleagues. They showed that if you give a mg per kg of omeprazole orally, about 4 hours prior to the anaesthetic, that significantly reduces gastroesophageal reflux. Now, for those of you that were at Darren Kelly's talk this morning, he already mentioned this, but there's now a number of papers that show ranitidine does not alter gastric pH in dogs. So it's probably fortunate that it's not available at the moment unless it's come back on, but ranitidine does not have a place in reducing gastric pH. You have to use omeprazole. The study by Poinsett, a subsequent study by Poinsett in 2006, he also showed a reduction in regurgitation if he used a combination of omeprazole, sucralfate, which I'm not quite sure why the sucralfate was there, and cisapride. Now, cisapride is not always that straightforward to get, and in fact, sometimes we can't get it at all. So we've kind of modified the protocol. And the current protocol that we're following is we do the mg per kg of omeprazole orally at least 4 hours beforehand. And we also use metoclopramide to promote gastric emptying. Now, the dose of metoclopramide here is based on a study by Deborah Wilson, who's an anaesthetist in the States. And they used a bolus dose of a mg per kg intravenously, followed by a constant rate infusion of 1 mg per kilo per hour during the anaesthetic, dropping down to 1 mg per kilo per day post-operatively. Now, two things from that. These doses are significantly higher than the licensed doses of metoclopramide in the UK. But in this study, they found that lower doses did not significantly affect gastroesophageal reflux. At these doses, they had a 54% reduction in reflux, but lower doses didn't seem to work. So you're using this off license because it's high doses that we're using. And one thing to be aware of is that metoclopramide can cause extrapyramidal signs. So the extrapyramidal system in the body is what kind of affects our involuntary muscle tone. And when we use very high doses of it, it's possible that you can see things like muscle tremors, muscle rigidity, muscle spasms. Now, I've never seen it, and we use this a lot, but it is something to be aware of. If you do see signs like that with metoclopramide, if you simply stop it, the blood levels drop fairly quickly, and usually you don't need to do anything else. Now, one other issue with metoclopramide is our standard metoclopramide preparation has been Emiprid. That's the one that we tend to use. But as I'm sure some of you are aware, it's currently off the market and probably not going to be available till late January. So we moved over to the other licensed veterinary preparation, which is the DECRA one, VOM-END. Now, this is not licensed by the intravenous route, and it contains benzyl alcohol as a preservative. So if you were to use this at the high doses that I mentioned intravenously, there is a theoretical risk. It's a very low risk, but it's a theoretical risk that you could get benzyl alcohol toxicity with that preparation. So what we're currently doing is we're only using the VOM-END for single intramuscular injections, and if we're giving it intravenously, we're using a human generic preparation at the moment that doesn't have benzyl alcohol preservative in it. When Emiprid comes back on, obviously we'll go back to that again. Now this is a bit of a no-brainer, I guess. This was a study. There's always some unusual studies out there when you start looking in the literature. But about 80% of dogs demonstrate stress in a veterinary environment. Not a big surprise, is it? But I think it's particularly important, if we look at things like the brachycephalic dogs, I think it becomes even more important because the more stress they get, the worse their airway becomes and the more likely they are to obstruct. So I think it's really important when we're dealing with these dogs that we provide anxiolysis for them. We try and keep them calm. And I guess our standard anxiolytic drug for many years has probably been acepromazine. But we now know that acepromazine is not a very effective anxiolytic at all. It's fine for pre-medication, for instance, before anaesthesia, but it's not good orally for anxiolysis. And in fact, the behaviourists would now suggest as well it can create a locked-in sensation. So in other words, the animal still feels as stressed as it would if it didn't have the drug on board, but it's not able to move or demonstrate outward clinical signs. So ACP has largely gone out the window as an anxiolytic. And the drug that we tend to use is a drug called trazodone. Now lots of information available about this in the veterinary field. It's actually a human drug. It's very widely prescribed as an anxiolytic in humans and as an antidepressant. And there's quite a wide dose range. It comes in 50 and 100 milligram capsules. You can also get 150 milligram tablets, but they're more expensive and harder to source. But we usually start off with a dose of roughly 3.5 mg per kg by mouth. So for most of our brachycephalics, for most of our Frenchies and things like that, we're usually just given the 50 milligram dose. Okay, it's more than 3.5 mg per kg, but we tend to give the 50 milligram capsule. Has an onset within about 45 minutes. You certainly usually see an effect within about an hour. And although most people probably use it once a day, it's becoming more common to use it twice a day, and you can increase it to 3 times a day if you need a longer period or more intense anxiolysis. So what we're currently doing now is when we have a brachycephalic being referred to us, we've just changed our protocol so that the referring vet starts these dogs on omeprazole and trazodone before they even get to us. We get them to try and start it the day before, start with both of these drugs, so that we can reduce gastroesophageal reflux and that the animal's nice and calm when it comes into us as well. Now, trazodone is a serotonin antagonist and reuptake inhibitor, and this means it increases the levels of serotonin in the body, which by itself is not a particular problem. But when you combine it with other drugs that are also serotonergic, that also increase serotonin levels in the body, it's theoretically possible to get a serotonin syndrome. And the signs of serotonin syndrome are down there on the bottom right-hand side of the slide. Now, serotonin syndrome is very, very rare, but it can occur. So whenever you're using these drugs, you have to use them fairly carefully. So the problematic drugs with trazodone are the behavior-modifying drugs. So the tricyclic antidepressant clomipramine, the monoamine oxidase inhibitor selegiline. If you combine those and give them alongside trazodone, you may precipitate serotonin syndrome. The other drug that you should probably be aware of that's also serotonergic is tramadol. So I would not give tramadol alongside trazodone. If I have a BOAS case that I know is on tramadol, I won't give it trazodone. I would withhold it. But very, very rare, but a theoretical risk that we can avoid. So we're almost halfway through the talk, and so far I've not really mentioned anaesthetic drugs at all. And that kind of emphasises what I'm really saying about BOAS anaesthesia. It's not really all about the drugs. But I guess when we start to think about the actual anaesthetic protocol, the main thing we're concerned about with these patients is their ventilatory function. So when we're looking at pre-medication drugs, we want to choose ones that don't really cause respiratory depression. Unfortunately, none of the common drugs that we use do cause respiratory depression when we use them as pre-medicants. Even the alpha-2 agonists don't really cause significant respiratory depression. But the mere act of sedation in these dogs can actually worsen their ventilation. So it may be that the animal adopts a certain position to try and maximize airflow into its lungs, and when we sedate it, it's no longer able to maintain that position. Or it may be that they're really struggling to breathe, and just the fact that we sedate them takes away that conscious effort, and they start to hypoventilate and start to obstruct. Another thing that can happen is if we use pre-medicant drugs that cause some muscle relaxation in particular, we can get collapse of the pharynx, we get relaxation of the pharyngeal tissues, and that can lead to obstruction. So the important message from this is that even although we are using pre-medicant drugs that are not respiratory depressant, it's really important that as soon as we administer pre-medication to these patients, they're under constant observation so that they don't obstruct. And if they do start to obstruct, we are prepared to immediately anaesthetize them and get an endotracheal tube into them. So you need everything set up in advance for induction before you even pre-medicate these dogs. I actually prefer, before giving them any drugs at all, to place an IV cannula if possible, so that if things do go horribly wrong, we can immediately anaesthetize these patients. If the animal starts to get stressed during this procedure, then we abandon it. We just stop it and we just let them calm down, and then we administer the pre-medication drugs. But I think essentially it's better to have an IV line in if at all possible. And then what drugs do we use for pre-medication? Well, the acepromazine, obviously the longest acting pre-medicant agent we've had available. It's got a fairly long duration of about 6 to 8 hours, which may or may not be desirable depending on what you're doing to the patient. It gives us fairly mild sedation, and at the doses we use clinically, it's a perfectly safe drug in brachycephalics. Again, I would emphasise there is absolutely no evidence at all that there is a problem with acepromazine in any of the brachycephalic breeds, with the possible exception of the boxer story that I mentioned beforehand. So acepromazine is fine. If that's what you're used to using all your other dogs, then go ahead and use it in these breeds as well. The alternative agents are the alpha-2 agonists. Now, I've come across in some textbooks it says, you know, the brachycephalics have high vagal tone, so you should avoid these drugs or at least use reduced doses because they also increase vagal tone. In fact, it's very common to see things like second-degree AV blocks in brachycephalics, even when they're conscious, even before you give them any drugs. And my impression is that even although they have pre-existing high vagal tone, giving them an alpha-2 agonist doesn't make them any more bradycardic than it does any other breed of dogs that we deal with. So I don't think there's any problem at all with giving these drugs to these patients. Obviously, it gives us the ability to have more marked sedation. It's probably more titratable to use an alpha-2 agonist than acepromazine. You can get a better handle on how much sedation you need. We get greater muscle relaxation, but probably the big advantage is we have a specific antagonist. We've got atipamezole, so that if things do go badly wrong or they're having a very prolonged recovery, we can antagonise, which we obviously can't do with acepromazine. And regardless of which of the two groups of drugs you use, acepromazine or an alpha-2 agonist, we're obviously going to combine it with an appropriate opioid depending on the procedure that the patient is going on to have. So the most common pre-medication I would use in a brachycephalic case, a BOAS case, would be a combination of medetomidine and usually methadone if they're going for any surgical procedure. I'd use butorphanol if it's a non-surgical procedure. I prefer medetomidine over dexmedetomidine, and the reason for that is that I think it provides more predictable sedation and better sedation, and there's at least one paper that confirms that that's the case. So I did use dexmedetomidine, and we've switched the whole practice back over to medetomidine, and it's also cheaper obviously because it's generic as well. So fairly low doses we're talking about. You know, if I can get the IV cannula in the patient before pre-medication, then I'll go for a low-dose IV combined with the methadone. If I can't get an IV cannula in because the patient's stressed, then I'll use a slightly higher dose, even up to 5 micrograms per kilo IM of medetomidine combined with methadone. Now, when it comes time to induce anaesthesia, it's important that we try and pre-oxygenate patients for 3 minutes by mask. We do this with all our patients, and I'll tell you why in a second, but it's particularly important in the brachycephalics, particularly if they have BOAS. If the patient starts getting stressed when we're trying to pre-oxygenate them, then it's better abandoning it because they'll actually increase their oxygen requirements more than we can supply if they're trying to take the mask off. And if that's the case, we'll take the mask away from the patient, we'll turn up the oxygen flow meter and just hold the tube as close to the patient's face as we can. So that's flow by oxygen. Much less effective than having a nice tight fitting face mask but if the animal resents it, flow by is better than nothing. One thing I would say is that we find the standard veterinary face masks suboptimal for brachycephalics. And that's because they tend to be quite far away from the face, so you get quite a lot of dead space, but also because the edges tend to rub on their eye. So these are human face masks that are used prior to induction of anaesthesia to pre-oxygenate us if we go for an anaesthetic. They're single use, so the hospitals toss them out, hundreds of them every day, and they're quite happy to give them away to you. But they also have ones that are pre-packed that have gone out of date, which they throw away. This is why we're destroying the planet. But you can pick these up from your local hospital as well. They're more than happy to give them away. And as I say, they fit really nicely on the brachycephalic breeds. You get right close to the nose, and they don't tend to rub on the eye. So why is it important to pre-oxygenate? Well, whenever we induce anaesthesia in any patient, oxygen will drop. The diaphragm relaxes, the functional residual capacity in our lungs goes down, and therefore we want to try and get the oxygen stores up as much as possible before we induce anaesthesia so that patients don't become hypoxemic. We also know from studies that brachycephalics already have lower oxygen levels in their blood than non-brachycephalic breeds. So they've even got less of a buffer than other breeds have. They're more likely to desaturate than a normal breed would be. And finally, they're more difficult intubations by and large than standard breeds are. So if we struggle to get an endotracheal tube in, their oxygen's going to go down even further. So by pre-oxygenating them, by filling the functional residual capacity in their lungs with oxygen, it gives us plenty of time at induction of anaesthesia if anything goes wrong. Without pre-oxygenation, they'll desaturate within about 20 seconds. With pre-oxygenation for 3 minutes, you'll have a good 3 or 4 minutes, even if they become apneic, even if you can't get a tube in before they start to desaturate. So induction drugs, what should we use? Well, I've already presented the evidence about mask induction, which seems to be the preferred technique across all the forums. I did come across another one that said induction should be with Valium or ketamine. I think they actually mean Valium and ketamine, which is a very standard combination in North America. So mask induction should really be the way to go, according to all these people. What I would say to you is mask induction in brachycephalics is absolutely 100% unequivocally contraindicated. So don't believe what you read on the internet. The reason it's contraindicated is twofold. Firstly, when we do a mask induction, there comes a point in it where the animal is not sufficiently conscious or sufficiently aware to maintain its own airway patency, but they're also not sufficiently unconscious for us to pass an endotracheal tube. So neither us nor the patient have control of the airway. The second reason is because of the high incidence of gastroesophageal reflux and potential regurgitation, if the animal starts to regurgitate at some point in the middle of a mask induction, again, they can't protect their airway, we can't do anything about it, and there's a significant risk of aspiration and subsequent pneumonia. So mask induction, regardless of whether the French Bulldog breeder comes into you and says, I want the dog mask induced, it's contraindicated 100%. So induction should always be with an intravenous technique. And really, I don't think there's much to choose between propofol and alfaxalone. I induce with whichever drug I come to first in the cupboard. And that's not very good for an anaesthetist to say, but I don't think there really is much difference between them. If the animal has a very low heart rate after pre-medication, let's say I've given an alpha-2 and its heart rate's really low, it's in the low 40s or maybe even dropping into the 30s, I'll tend to choose alfaxalone because it's more likely to increase the heart rate. Apart from that, I really don't think there's a huge difference between these two drugs. Before you induce, though, you want to make sure you've got secure IV access. These are definitely not cases you want to be inducing off a needle. A light source, preferably a laryngoscope, so you can see what you're doing, and a range of endotracheal tubes, including some that are significantly smaller than what you anticipate that patient's going to take. For the following reasons, tracheal hypoplasia is one of the parts of the BOAS syndrome. Now these radiographs, these thoracic radiographs, are from 2 dogs of the same body weight. The one down at the bottom is a normal conformation dog. If you look at the diameter of that trachea, up at the top here, we have a brachycephalic dog. So the trachea, significantly smaller, and that's going to limit the size of the endotracheal tube you can get in there. The other thing is a lot of these dogs have laryngeal collapse, and although this is a flaccid collapse, although the larynx isn't fixed, it does make it slightly more tricky to get a tube through there. So you may struggle a bit with a larger tube. And similarly, because a proportion of them also have everted laryngeal saccules, these can get in the way when you're trying to pass a tube and may slightly limit the tube size you're going to get down. This is my record dog. So this was a 28 kilogram English bulldog that I had to intubate. And any guesses as to what size tube I ended up putting in it? Somebody said it right away, amazing. This dog took a size 5 millimeter endotracheal tube, 28 kilos. Now a size 5 is the standard size I put in a cat. So we're saying that these two patients, one being almost 10 times the size of the other, have identical sized tracheas. And then we wonder why these poor guys can't breathe at all. The other thing to be aware of at intubation is if the animal is having non-BOAS surgery, if it's having an anaesthetic for something else, be as atraumatic as you possibly can with your intubation. The reason for that is every single patient we anaesthetise and intubate, we damage the airway, we traumatise the airway, and we will always get edema in every case. Now, in most animals, that is not significant, it's not problematic. But when we're already starting off with animals with compromised airways and we make them swell up even more, and therefore make them smaller, that can be very significant in BOAS cases. Obviously, if they're having airway surgery and the surgeon's going to chop half their airway out, it doesn't really matter how traumatic we are when we intubate, they're definitely going to get edema. Now, I read something recently by one of my anaesthesia colleagues in the UK, and he said anaesthesia should be induced slowly to effect. I completely disagree. I think induction of anaesthesia in BOAS cases should be as a rapid sequence induction. And what that means is, rather than trickling the agent slowly to effect, we give the full calculated bolus straight in as fast as we can. And the reason for that is, once we've done that, we then immediately secure the airway, so we pass an endotracheal tube and we inflate the cuff. And the reason for doing a rapid sequence induction is, it means we go from a situation where the animal is fully conscious and hopefully able to control its own airway, to a situation where it's unconscious and we can control the airway in as short a period of time as possible. So in other words, if they start to regurgitate, we have control of the airway or they have control of the airway. Now there is a downside to this, and I can see why other people say do it slowly, because when we do a rapid sequence induction, it's likely to induce apnea in the patient because we generate higher blood concentrations and brain concentrations of the anaesthetic agent than if we trickle it very slowly. That depends whether you're worried about apnea. I don't worry about apnea. Animals don't die from apnea, they die from hypoxemia. Rapid sequence induction will also tend to drop the blood pressure more than if you did a very slow controlled induction. Again, this is not usually a problem unless the animal's hypovolemic. So if they're normal volemic, it doesn't matter too much. But I guess more of a problem for us is that quite often if the animal is presenting for BOAS surgery, then the surgeon wants to look at the airway, in which case, we've just given a big bolus of induction agent, the animal's apneic, we can't intubate because they want to look at what's going on down its throat. So if we have a BOAS case that's going for non-BOAS surgery, orthopedic surgery for instance, I will do a rapid sequence induction. If we have one that's going for airway surgery, I'll do a slow controlled induction so that the surgeon can look at it and hopefully the animal continues breathing. If we can't do a rapid sequence induction, then it's important we position the patient appropriately until we have an endotracheal tube in place. Now, gastroesophageal reflux and regurgitation is a passive process. So if we can maintain the animal in this position after induction of anaesthesia, sternal, head elevated, we're using gravity to help us because hopefully gravity will stop any regurgitation coming up to the pharynx. It will just make it sit in the esophagus. So we keep them in that position until the endotracheal tube is passed and the cuff is inflated, and then we let their head come down. If they're in this position and they do start to regurgitate, then we immediately drop their head off the side of the table so that it will drain out their pharynx. And it's also important in induction of anaesthesia with these cases to have suction available because you have to be able to suction the pharynx out if they do start to regurgitate. For maintenance of anaesthesia, I guess for most of you the choice is between isoflurane and sevoflurane. I don't actually think there's a huge difference between these two drugs. Probably at least 90% of my cases are anaesthetised with isoflurane. Probably about 2% are anaesthetised with sevoflurane. And what we use for all our airway surgeries is a drug called desflurane, which most of you probably haven't come across. It doesn't have a veterinary licence, but it's got the lowest blood gas solubility of any of the inhalational agents, which means it's the fastest onset and fastest offset. So you get spectacularly fast recoveries with this drug if you use it. And if you get it right, you can literally have the patient walk out of theatre by itself because they have such sharp recoveries. And the idea behind this is if they recover fast, it also means they're going to have control of their airway fast as well. So we're just actually starting a study with one of our residents comparing desflurane and sevoflurane to see if there's fewer, what's the word I'm looking for, not interactions, interventions we need to do in recovery with one drug over the other. Now, because we're tending to put quite small tubes in these patients because of their small airways, it's very common for them to hypoventilate during anaesthesia. And we'll detect that on our capnograph. We'll see an increase in our end-tidal carbon dioxide concentrations. And if they are hypoventilating, we have to undertake manual ventilation simply by squeezing the reservoir bag on the breathing system. Now, we don't usually start ventilating, although people will say, 35 to 45 is the magic number for end-tidal CO2. I wouldn't start to ventilate in a healthy patient until the CO2 is up about 55, even 60, before I'd even do anything particular about it. One other thing that small brachycephalic breeds will often do is they tend to adopt a very rapid, shallow respiratory pattern. So you see this on your capnograph, and their end-tidal CO2 looks like a relatively normal number. If you see this kind of pattern and you give the patient a manual breath by squeezing the bag, you'll quite commonly see your trace goes up much higher then, and that's actually giving you a truer reflection of what your end-tidal CO2 is, and will tell you whether you need to ventilate or not, because it will usually be significantly higher than the number that's being displayed on the screen. Now, obviously, we also try and keep patients warm during anaesthesia. We need to be very cautious with the brachycephalics, particularly those with BOAS, that we don't overheat them, because we really don't want these guys starting to pant a lot in recovery, because that compromises or can compromise their airway and their ventilation further. As I said, because we use smaller tubes, they tend to have higher resistance, but the other thing that's more likely to happen is they're more likely to obstruct because of mucus or blood, for instance, in the airway. So we've got a normal capnogram here on the side. We've got a nice rapid upstroke during exhalation. And if we look at this capnogram here, you can see that instead of a nice rapid upstroke, we've got this very slanted upstroke. And we don't actually get an alveolar plateau. It just goes up and then it comes back down. And this is what we call a shark fin capnogram, because it's the same shape as a shark's fin. And this tends to indicate expiratory resistance. And one of the commoner causes of that is partial blockade of your endotracheal tube. So it's something to be aware of in brachycephalics, and just check what the tube's doing if you see this kind of pattern. Now, another area that we need to think about when we're doing these cases is their eyes. We need to take care of their eyes. Much higher instance of corneal ulceration than other breeds. Obviously, the eyes sticking out, predisposed to drying out. And also, it's been shown in studies that the brachycephalics have lower corneal sensitivity. It was compared to Labradors. They're less sensitive, their corneas, so they don't really realise when something's wrong. But also, when we anaesthetise them, they then stop blinking, and the eye's likely to dry out further. We also know from a number of studies that some of the opioids, the inhalational agents, medetomidine, all decrease tear production. And so again, this predisposes to more corneal damage during anaesthesia. And it's also been shown that if the anaesthetic lasts longer than 2 hours, the tear production is reduced for up to 24 hours. So it's not just a case really of protecting and lubricating the eyes in these cases during the procedure. You probably need to keep doing it every couple of hours for up to 24 hours after the anaesthetic to prevent corneal ulceration. Okay, so what about analgesia? Well, the opioids by themselves are not really respiratory depressants in animals. They're not clinical respiratory depressants. However, they may contribute to prolonged recoveries in some cases, and they may predispose to ileus, which may worsen the incidence of gastroesophageal reflux. So it makes sense for us to try and adopt a multimodal approach to analgesia to try and keep down the amount of opioid analgesics we use. So we might use local anaesthetic techniques. So this is an epidural, for instance, not particularly useful for BOAS surgery, obviously. And then we need to think about non-steroidals if the patient hasn't received steroids, or perhaps IV paracetamol if the patient has. So generally what I'll do is if the animal is presented for airway surgery, all of these cases will get corticosteroids as part of their anaesthetic protocol to reduce swelling, in which case they then get IV paracetamol during the procedure as their perioperative analgesic. So they get 10 mg per kg of paracetamol, usually given over about 20 minutes and repeated 3 times a day if they've been given the steroids. If the animal is having non-BOAS airway surgery, if it's having, say, orthopedic surgery, I'll assess the airway at induction of anaesthesia. If I think it's going to be a problem, then I'll withhold non-steroidals in case we need to give steroids during recovery. If I look at it and I think this airway is not that bad, then I'll give the patient non-steroidals at that point on the basis that we're very unlikely to have to give steroids. The anaesthetic recovery is the time of greatest danger for these patients because we go to a situation where we really can't do very much about maintaining the airway as they recover consciousness. And in fact, it's not just brachycephalics when this is a problem. CPSAF is the confidential inquiry into perioperative small animal fatalities. So it was a massive anaesthetic mortality study conducted in the UK by Dave Broadbelt at the Royal Veterinary College. And I think we all tend to think about anaesthetic deaths as things that happen on the table during the procedure. And in fact, what Dave showed in this CPSAF study, which was his PhD study, he found that about 50% of dogs who died with anaesthetic-related causes died in the recovery period. But more than 60% of cats who die related to anaesthesia die in the recovery period. And of these deaths, about half of them died within the first 3 hours after the anaesthetic. Now this is likely to be even higher with the brachycephalic breeds, but I think it's just interesting to note that the peak mortality with anaesthesia is actually in the recovery period anyway, and it's within the first few hours that it happens. So what can we do to try and minimise these problems with brachycephalics? Well, obviously we try and avoid getting them stressed in recovery. Hopefully we try and do that anyway with most of our patients. I think ideally we want one-to-one supervision until these patients are fully conscious and sitting up. Although having said that, I've had some of them obstruct several hours after the anaesthetic. They've been fine initially. But I think ideally you want one-to-one nursing care if you can. For the particularly high-risk ones with severe laryngeal collapse, for instance, I'll place a nasotracheal cannula to supply oxygen. Now this is something I couldn't really get on video because it's quite difficult to video. But all you do is you use a compliant tube, like a feeding tube. You pass it down their nose. You have to then remove the endotracheal tube. You look into their pharynx with a laryngoscope and you see the tube start to appear at the back of the nasopharynx. And you can then put in long forceps, grab it and direct it into the trachea, and then you just secure it around the nares and on the face. And you can actually, that means you can supply oxygen distal to the larynx. So it doesn't really matter too much if they've got laryngeal collapse. And they tolerate that very well. The main problem is you have to remove the tube before they recover to place the nasotracheal cannula, which may be suboptimal in some cases. I showed you a picture of a CPAP hood before. These are these hoods that supply constant pressure into the airway and help maintain it open. And we're also about to start a study on that in our brachycephalic dogs to see if it works. But I didn't have a dog handy. So this is Anna, who's my resident, so I just made her wear the hat, and she said she couldn't breathe in it. So I'm not quite sure how well we're going to do with these dogs, but we'll try it anyway and see how it goes. This is a picture I really don't want to see in our practice, and I do see it unfortunately. And that is a patient who has an endotracheal tube in who's not connected to any oxygen, who's breathing room air. Why is this a bad thing? Why should we be supplementing oxygen for as long as possible? Well, at the end of an anaesthetic, a patient's always going to have residual respiratory depression because all the drugs we use are respiratory depressant. So until they're fully conscious, they have that residual depressant effect from their anaesthetics. And if they're breathing room air, that respiratory depression may well make them hypoxemic. The second reason is if you're standing around a dog like this at the end of an anaesthetic, you're inhaling trace concentrations of waste anaesthetic gases. It's It's not good for your health. So you want those gases to be scavenged for as long as possible away from that patient outside your clinical environment. And thirdly, if this dog gets extubated and it then obstructs its airway, it's got no extra oxygen stores in its lungs. It's going to desaturate really, really quickly. If you have it connected to oxygen up until the time of extubation and something goes horribly wrong, it means you get plenty of time to sort it out. The animal's not going to desaturate for a good few minutes. I guess most of us try and keep the endotracheal tube in as long as possible, essentially until the animal extubates itself or won't accept the tube for any longer. Again, something else I came across in a textbook from an American anaesthetist, they actually recommend pulling the tube early to prevent laryngeal spasm. The dogs don't get laryngeal spasm. It's cats that get laryngeal spasm in small animals, so I've got no idea where that came from. But one technique for keeping the tube in as long as possible is just to have a layer of vet wrap around the tube so that if the dog does happen to bite down, it's not going to occlude the tube, it's only going to get caught on the vet wrap. I once had a horse, actually I was just thinking about this last night when I was in the States, and we did a horse and we recovered this horse with its endotracheal tube in, and the horse got up and went headfirst into a wall of the recovery box and knocked its endotracheal tube right into its mouth, and it then closed its mouth, and the tube was inside and this horse would go and horses being horses and not the brightest of creatures, it didn't actually think to open its mouth again to take a breath. And we had to re-anaesthetise it to get the tube back out and secure it again. So I think it's much less likely to happen with brachycephalics. They accept the tube much more readily when they're conscious, but you do need to keep an eye on them and just make sure they don't bite through it and inhale it, because I have heard of that happening as well. All of our BOAS cases go back to the ward with a tray for re-intubation should it become necessary. So it has an induction agent, has a laryngoscope, and has a series of endotracheal tubes if the nurses need to step back in and intubate this dog. And I think the other thing to be aware of is it may be a more difficult intubation this time than it was originally if you've got significant airway swelling. So this is just a video. This happens to be an English bulldog. This dog didn't actually have a particularly bad airway, but I was just doing the video to show how we manage it if something does have a bad airway that we can't visualize particularly well. So there's no sound with this dog. You'll see I put the laryngoscope in. Some people put the laryngoscope on the epiglottis. You can see the epiglottis just at the back here. You'll notice I've got the laryngoscope between the base of the tongue and the epiglottis. That's an area called the vallecula, and that's where you're supposed to have it. I'm now introducing, this is a gum elastic bougie, and I'm placing this through the larynx. Now equally in practice you could use a wide bore urinary catheter if you're having a difficult intubation. Never ever ever let go of it, because the animal could inhale it. Unfortunately I left my endotracheal tube too far away. So you then get the endotracheal tube, pass it over your bougie or your urinary catheter, get the end of it, and then you can just blindly slide it in. And it means if you can't visualize very well or it's a difficult intubation, the endotracheal tube will follow the line of that guide and it will go down into the trachea. So how do we recognize that we've got an obstructing patient? So we get an increase in respiratory noise, and then in fact it may decrease as the animal gets to the stage of full obstruction. And again, I've had people say to me before, oh, it's getting quieter, it's getting better. It's not. If you look at them, their sides are heaving, they're struggling to breathe, but you just don't hear any noise anymore. If they're conscious, they'll often become more agitated as they get hypoxemic. And one thing that seems to happen a lot is they become hyperthermic. So you see charts, if somebody's been recording their temperature, you see their body temperature starting to rise and rise and rise, and that can be an indicator that they're about to obstruct. It's the increased muscle action that's increasing their body temperature. I think it's important that we anticipate which cases are most likely to obstruct, and it tends to be the ones that have had intralaryngeal surgery, so everted laryngeal sacculectomies, or ones that have got severe laryngeal collapse. Those are the ones that you need to be prepared to re-intubate if necessary. If they start obstructing, we try and supply supplemental oxygen by whatever means, and we sedate them as well. Now, there's various doses written down. Again, I use meditomidine, and I usually use a 1 to 2 microgram per kilo bolus IV followed by a constant rate infusion. If you look in most of the textbooks and most of the articles, they'll say the constant rate infusion should be 1 to 2 micrograms per kilo per hour of medetomidine. That's actually the analgesic dose of medetomidine, and to get sedation, you often need to go significantly higher than that. So you may have to go up to 5 or potentially even 10 micrograms per kilo per hour in some of these patients if they're really stressed. If they haven't had corticosteroids as part of their anaesthetic protocol and they're starting to obstruct, we'll give them dexamethasone at that point. Bear in mind, a lot of people don't seem to know that dexamethasone can cause massive vasodilation when you give it IV. You can't give it quickly, you have to give it slowly. I've killed one patient by doing that under anaesthesia. I gave a bolus of dexamethasone and it immediately arrested and I couldn't get it back. So just be aware, give it very slowly IV. If they continue to obstruct, we're going to re-anaesthetize them at this point. And sometimes just re-anaesthetising them and passing an endotracheal tube and keeping them anaesthetised for a couple of hours is enough to allow the steroids to work, and then you can safely extubate them. Unfortunately, ultimately, for some of these patients, we're going to have to do tracheostomies to get them through this initial period of the swollen airway. One other thing that we can do to try and minimise obstruction is to nebulise adrenaline. Now, I was looking the other day, you can buy nebulisers on Amazon for 40 quid, so it's a very cheap technique. We take 1 milligram of adrenaline, which is usually 1 ml of the standard solution, put it in 5 ml of sterile saline. Notice you can't use water here for dilution because it causes bronchoconstriction. When you nebulise it, it has to be saline. And when we give the adrenaline, it will cause localised vasoconstriction, so it will reduce the amount of swelling and edema in the airways, and it can be very effective in some of these cases. It's also a bronchodilator, adrenaline, but that's probably a much lesser effect. Most of the effect's probably on the upper airway at reducing the edema. And we tend to repeat that usually every 6 hours for about 10 minutes, provided the dog will accept it without getting stressed. Now, given all these problems that we have with anaesthetising cases with BOAS syndrome, is it better to do things under sedation? Well, the answer to that is, although a lot of owners think sedation for most cases is much safer than anaesthesia, and although a lot of vets do as well, in actual fact, anaesthesia is probably safer in most situations than very profound sedation. And that's because with anaesthesia, we usually monitor them more closely, we protect their airway, which is particularly important in the brachycephalics, and we usually supplement oxygen as well. So for brachycephalics, unless it's very light sedation, which will produce the desired effect, it's always better to go straight for general anaesthesia. Even if that's just for a quick radiograph, anaesthesia would be preferable. So in summary, hopefully you'll have learned that most of this talk hasn't been about anaesthetic drugs at all. It's really been about perioperative support. So it's not really about which drugs we choose, it's about thinking about all these other things that go wrong during these cases. But you can do all of this 100% correct and things will still go horribly wrong with these dogs. And there's no way we can get around that. That happens to all of us. It's all about being aware in recovery and waiting to step in when things do start to go wrong, re-anaesthetise, potentially tracheostomies. And that's it. Have we got time for questions? Or?
Yes, we do.
We do have time for questions, apparently.
So we've got about 5 minutes and we've got a roving microphone.
Hi, thank you. Really interesting talk. Bradley Vine, a veterinary surgeon. It was very comprehensive, but the one area that you didn't deal with was consent. I chair the preliminary investigation committee at the Royal College, and people here will not be surprised to know that maybe that's why there's so many people here, that complaints for death, particularly relating to elective procedures in brachycephalics, is very much on the rise. And when owners lose a much loved pet, then they tend to look for someone to blame. Actually, informed consent for the owners is incredibly important. I think that your lecture for me has actually reinforced the fact that there are very special considerations for these breeds. So I'd like to just make the point that having properly informed consent and recording it's really important. But as a question to ask whether you're familiar with the use maybe of consent forms that are specifically designed for BOAS cases that can act as a framework.
No, we don't, because we were always of the understanding that our general consent form, which says we may have to use unlicensed drugs as part of the patient's treatment in hospital, covers us. That's what we've always been told by the VDS. And it was only if you were given an unlicensed drug home with the patient that you had to get specific informed consent.
Yeah, but the point I was making really relates to the fact that when things go wrong, and as we've seen that they will sometimes, owners will then question whether their consent was truly informed. And for that to be informed consent, they have to have the particular risks explained with that particular dog. Otherwise they'll say, well, I never knew that my snorting bulldog was more likely to die under anaesthesia, and therefore I didn't give informed consent for the procedure. I would never have had it done.
It's not I have to say it's not something that I deal with, because it would be our surgeons who would tend to have the conversation with the clients. But I would assume, I would hope that they are saying to the clients, these are higher risk cases under anaesthesia than a normal case would be. So to me, that I'm not quite sure how much more informed consent we can do than that, because we can't really say, well, if the dog obstruction recovery, we may have to give it adrenaline, we may have to do this, we may have to give it all these off-licensed drugs. So I'm not really sure I'm getting your question. Are you just saying we need to say there's a higher risk, or?
Yeah, when things do go wrong, then it's not about the drugs that are used, but the fact that the owners will claim that they haven't been made aware of the special risks, and actually just saying them and not recording them and formalising that makes it much harder to defend when things go wrong.
So just to clarify, are you suggesting then we do have a specific brachycephalic consent form?
Well, I'm suggesting that there needs to be specific consent for brachycephalics, and asking whether you or anybody else has experience of using specific forms that actually underline the risks and make it very clear to the owners so that they cannot deny that they've given informed consent, truly informed consent.
Yeah, I certainly haven't come across any. I don't know, maybe people in the audience do use specific consent forms, but I've certainly not come across it. Does anybody have a specific form that they use for brachycephalic? Yeah, just write down what the, yeah. The question down at the front is, surely you just have a conversation with the owners, but I think what Bradley's saying, is it has to be documented that you've had that conversation. I think I think equally you could end up having a separate consent form for caesarean sections. I really don't know where you stop, if you have to have everything documented. I'm just not sure it's feasible. So I take it what Bradley's saying, but I'm just not sure how feasible it is for all the situations that we face.
Okay. You mentioned earlier about not sort of getting them to hyperventilate. I know some dogs with methadone, they do tend to hyperventilate. Is there any point in doing something like a milk drip rather than methadone?
Do you mean, so did you say hyperventilate or hyper?
Yeah, hyperventilate.
You mean panting?
Yeah.
Because they're not truly hyperventilating, because their CO2 is not, so they pant. Yeah, I mean, it happens. I think it's unpredictable which dogs it will happen in. I mean, we're kind of fortunate in that all of our anaesthetic machines have got incorporated ventilators. So if they start panting and being pains, we just flick a switch and it takes over from it. I don't think there's any real advantage to doing it as a CRI over giving it as an intermittent dose. I think you may well still get panting as you achieve therapeutic concentration of the drug. Unless, do you mean morphine in your MLK, or do you mean morphine? I mean, you can get panting with morphine as well. You can actually get panting with any of the opioids, so I don't think you'd eliminate it by going from methadone to morphine. Plus it's off license, so you'd have to, I don't know how you'd justify that. Anybody else? Is that it?
You want more?
Yeah, one more at the back.
Hi there. Oh, sorry. I just want to ask specifically for the BOAS surgeries, as part of my protocol, I always use the corticosteroids, and you put up the dose of 0.15 to 0.2. Is that your pre-med for the BOAS, or is that only if you're having problems as the...
No, so any of the cases in our practice who are having airway surgery, BOAS surgery, will get that as a routine before the procedure. Now, all of our surgeons, I have to say, I haven't had this discussion with them, but the nurses and I laugh about it, all of our surgeons have different doses for dexamethasone and they can't agree on it. And some of them have got really random doses like 0.125 milligrams per kilogram. There doesn't seem to be any science behind it at all. I think it's just about giving a dose of steroid, to be honest.
I'd got 0.25, but so I just
exactly
wondered.
That. You know, that's what I mean. There's so many doses in the literature. I don't think it's that important, to be honest.
In terms of the GI effects, I use a titrating dose of Preds afterwards. For is that still sort of standard practice, and with the GI safety as much as we know?
I think our surgeons only give the one-off dose unless there's a problem afterwards. I don't think there's any subsequent follow-up with steroids at all. I think it's just that one-off dose in the perioperative period.
Okay, that's helpful. Thank you.
There's 2 more questions, but I don't know if we've got time.
Yeah, we've got 1 more minute, so we can have probably just 1 more question, if that's okay. So, the lady at the back, sorry.
With use of omeprazole, you mentioned using it the day before surgery. In my practice, we tend to use it for about 3 days before, and potentially afterwards as well. Is that unjustified? Should we not be doing that?
Well, I think the evidence that we have is that if we give a single dose at least 4 hours before the anaesthetic, that has the effect on gastric pH. That's probably about as much evidence as we have. I don't think there's any problem doing it 3 days before and continuing it post-operatively at all. I mean, it's a relatively innocuous drug. And in fact, when we introduced this protocol, well, we're currently introducing it, of starting omeprazole and trazodone from the referring vet before they come in, we had a discussion as to how long we should start the omeprazole before, and I said, well, let's start at 48 hours before. And then some of the surgeons said, well, let's just start at the night before. So it was always a bit of a compromise. As I say, we have evidence that giving it 4 hours before seems to have that desired effect in terms of gastroesophageal reflux. But there's very few studies, there really are very few. So I think the compromise was really starting at the day before they came to us for anaesthesia. Starting at 3 days before? Yeah, great. Don't think it does any harm at all. We just tend to continue on the day of the anaesthetic, so we continue it for like 24 hours post-operatively, and then we tend to just stop it at the moment. Again, because we don't have good evidence that continuing it for longer makes any difference, because what we're really concerned about is gastroesophageal reflux, regurgitation, aspiration during the anaesthetic. Yeah, I mean, we know these dogs have got gastrointestinal abnormalities. All the studies show that. So carrying it on for longer until the BOAS surgery actually has an effect is a great idea. It's a good idea to continue it. How long? Who knows? Several weeks probably at least would be the ideal. It's off licence. I'll just say that in case Bradley's listening. It's not licensed, so make sure you get consent.
Okay, fantastic. Thank you, Derek, for such a great talk. It's really changed the way I'm going to think about it. And